Welcome back to the Better Health Now podcast. Today, I have the opportunity to sit down with Dr. Connor Ojard, a board-certified orthopedic surgeon here at Cullman Regional. Thank you so much for joining me.
Yeah, thanks for having me.
Yeah, I'm excited to talk about the topic of shoulder surgery. Before we dive into that topic, talk a little bit about your journey to get here to Cullman.
Sure. So I'm originally a native of South Alabama. I grew up down on Mobile Bay in Spanish Fort Daphne area. Went to undergrad at Samford University Medical School in Birmingham. So I had kind of been exposed to Cullman, and my parents built a lake house up here when I was in medical school. And eventually when we decided where we wanted to move my family after training, we started looking at areas in North Alabama and areas across the Southeast, but this was going to be a little bit better located for our family. And I had some good friends that had grown up in Cullman. I knew it was a good smaller town. And so that was kind of a big drawing point for me. So now we moved up here. I'm married. I have 3 kids. And my parents live out on the lake. And so we've got a good home base here in this area.
How long have you been here at Cullman Regional?
Been for 4 years now.
4 years. Okay. So talking about the shoulder surgery and as is the topic of discussion for today, what conditions or injuries typically lead a patient to have shoulder surgery?
Yeah. I mean, there's a couple different ways that we look at the shoulder. Certainly, a majority of our younger patients really have soft tissue injuries. So rotator cuff, labrum, biceps, more of the soft tissues that surround the joint itself. As we tend to get older, we have more degenerative changes that can develop on the shoulder. And so that's when we move more towards arthritic conditions, right? Most patients are familiar, with arthritis, but really what it is just wear and tear of the joint, wear and tear of the cartilage that covers the bone. And so that once you start having more arthritis enter the picture, it becomes a different type of surgery. So the surgeries that we tend to offer for shoulders can be soft tissue where we're scoping a shoulder. And that might be, again, a rotator cuff repair, a biceps tenodesis, a debridement. But then there becomes a point where those procedures just aren't going to cut it. If a patient has significant arthritis, you can fix a rotator cuff, you can, release the biceps, you can do these other procedures, but it's not going to make a big impact because the root of the problem then is the joint itself.
Yeah.
And so that's when we start talking about shoulder replacement.
Okay. And so how do you often see maybe a younger patient coming in and you do a rotator cuff or something like that, and then the potential, does the potential down the road for shoulder replacement become more likely if they've already had some sort of soft tissue surgery prior?
Yeah, I think that's a good question. So in theory, when you're doing a surgery like a rotator cuff repair, one of the major things that you're trying to do, other than pain and to increase function, it's to prevent the need for a surgery down the road. But, we would be, not accurate if we said that 100% of patients actually heal, their rotator cuff after surgery. Now, they can still do very well, but there's certainly a portion that don't heal. So, yes, I would say that, having a shoulder surgery means that you are more likely to get arthritis in that shoulder. But the main reason would be because you had that surgery for a reason, which is that you had an injury to that shoulder. So having an injury to the shoulder, I guess, would be the better way to say, predisposes you to having surgery. But yeah, one of the major reasons that we recommend, especially somebody in their 40s and 50s, rotator cuff surgery is because without that rotator cuff, you kind of uncouple the tendons and the muscles around the shoulder. And now all of a sudden the shoulder's not functioning efficiently and it's moving in a not natural, not native manner. And that can lead to increased forces, increased degenerative changes. And all of a sudden you get a certain type of arthritis in that shoulder.
For people with shoulder problems, at what point is that shoulder replacement the best option? And that is there sort of the stages at which, you see a patient come in and, hey, this is probably not going to fix it. This might, but the chances are low. And then maybe shoulder replacement's the way to go.
Sure. I think the easiest way to look at that would be to just look at arthritis, right? And so when I see a patient and I'm initially evaluating them, the first thing we're going to do is we're going to talk to them, look at them, examine them, but also to get an x-ray of their shoulder. And so you can get a really good idea for what the joint surface looks like with an x-ray. And so depending on what you see, if there's a fair amount of degenerative changes, bone spurs, narrowing of the joint, flattening of the humeral head, that tells us, okay, now we've got some pretty fair arthritis in the shoulder. but we can still treat that, So for plenty of my patients, especially younger patients that really can't go through with a shoulder replacement because they're working, they're lifting,
Mm,
especially if they're in a labor intensive job. There's other things that we can do, whether it's medications, physical therapy, injections.
mm,
Injectable treatments can be fairly effective. Now, there's pros and cons to those always because they are a medication, but certainly I've got plenty of patients that we're just doing that for now and trying to prolong their shoulder.
mm,
Um, then at some point, patients tend to fail these treatments. Now, not everybody does. Some patients can learn to live with shoulder arthritis.
mm,
I've got plenty of patients that I just have to say, yeah, this is arthritis. Certain activities are going to aggravate it or
mm.
irritate it, but if you can refrain from those, then maybe you can kind of continue how you're doing. And so that's certainly reasonable. But for the patients that have failed these conservative treatments, that's when we start talking about shoulder replacement.
Yeah. And so is there different sort of stages or different sort of shoulder replacement levels at which can be done for maybe someone with more extensive damage and needing to have a certain level of replacement versus someone that, hey, has tried other things that hasn't worked and
Mhm.
we just need to do it at this level?
Well, there's certainly some subtleties in terms of replacements, but I think the easiest way to understand that question is to look at the two major types of shoulder replacements that we have. So we have our kind of standard anatomic total shoulder replacement,
Mm,
which you take a ball and socket joint and you replace it with another ball and socket joint that matches up
mm,
with the original anatomy, just like it did. It's a bone preserving procedure where you're leaving as much bone as possible. You're just shaving enough of the humeral head to replace with metal. And then you're just taking enough of the cartilage of the socket of the glenoid so that you can implant a new
mm,
plastic spacer onto that. The important thing about a shoulder replacement, an anatomic shoulder replacement, is you have to have a functioning rotator cuff for that to be an effective surgery.
mm,
So those patients have primary shoulder arthritis. They don't have any other true soft tissue problems with their shoulder. Um, the thing that we see a bit more in our community, though, is patients that have maybe had an old injury, maybe had a surgery or not, and maybe they did just fine, or it got neglected for some reason or another, and now they've had a rotator cuff that's
mm.
been torn for years. So after 5, 10 years with a large rotator cuff tear, you're going to get arthritis in that shoulder. Those patients don't do well with the standard shoulder replacement. It just doesn't function well enough. You can help their pain, but it's not going to move because the forces, the tendons, they're not going to function the way that they're designed to. And so in that case, we do what we call a reverse total shoulder replacement.
Mm.
Um, the design for that is fairly complex and you can get into kind of precise mechanical aspects to it. But basically, you're taking a ball and socket joint, and that is the shoulder, and you're replacing it where the ball is where the socket used to be, and the socket is where the ball used to be. It's kind of hard
Huh.
for patients to
Interesting.
wrap their head around. It's hard to explain. That's why we keep models that we can show patients in the office. But the important thing is that it completely changes how the shoulder works. So it lowers and medializes the center of rotation of the shoulder. So now the big deltoid muscle, which everybody has, unless you've had a very severe injury or a neurologic condition, pretty much everybody has a good intact deltoid muscle. And so now that deltoid muscle can function to forward elevate, to
Mm.
lift, and to rotate the shoulder. So you can get a lot more function with a rotator cuff deficient shoulder with a reverse arthroplasty.
Yeah. So with those two different variations, depending on the patient's need and post health that they've had of their shoulder prior to the full replacement, how often are you doing one or the other? Do you, like you said, you mentioned
Mhm.
doing one more than the other one here, or does it kind of just depends?
Yeah, I think a lot of it just kind of depends on patient populations. I would say that just in my practice, I've had more of my patients that were getting to their shoulder in terms of replacements at a little bit older age,
Mm,
and so these are more patients in their upper 60s, low 70s, compared to patients in their upper 50s or low 60s. And so, for most of my patients, we evaluate them if they have, fairly typical arthritis, but it's questionable what their rotator cuff pathology is or what their rotator cuff condition is. We will get an MRI on their shoulder. And if it's compromised, if the rotator cuff is not well appearing and they're at an advanced age, then a reverse is just going to be a
mm,
better option for them.
yeah.
It's one surgery that we don't have to worry about the function of it as much as we would in that patient a total shoulder,
Mm,
and it's just an effective way to treat it. The other good thing is for some of those patients, they may have already been through a shoulder surgery, and rotator cuff surgery is painful. I mean, there's no way around it. It's a long recovery. It takes at least 4 months to start being able to use that shoulder in the
Wow.
same fashion that you did. Really takes 8 to 12 months to recover from a shoulder scope. When it comes to a reverse arthroplasty, you don't have to worry about the rotator cuff. In fact, if there's some unhealthy rotator cuff, you just cut it away
Wow.
from its insertion because it really doesn't serve a purpose at that point. Yeah, if it's healthy, you try to leave it because it can add some stability. But after that, we get the patients moving. And so for me in my hands, majority of my patients the day after surgery say that their shoulder, especially the deep aspect of their
Mhm.
shoulder, it feels better than it did before surgery. Every once in a while you
Yeah.
get some exceptions, but it's not as painful. The recovery, 6 to 8 weeks, and a majority of these patients are going about all their normal daily activities. Now, if there's certain extreme hobbies or activities, we might have to have them hold back on that.
Mm.
And then the other thing is there are some lifetime restrictions. So the majority of these patients, we don't want lifting more than 25 pounds with that arm, which that can be a little bit challenging. And that's
Mhm.
why some of my younger patients, we're just not, doing
Yeah.
a shoulder replacement. We're going to kind of keep them going, do everything we can to avoid it until we get to the point that we have to.
Yeah, and like I said, that recovery process. I mean, I had a recent family member that had some shoulder surgery done, and it's extensive, and it's like they think they did a carpal tunnel, and then they did the shoulder at the same time. And I mean, she was in a sling for a while, and you're kind of, you can't drive, you can't. There's a lot of things, and then I would say over the last 2 months, it's kind of been back to normal.
Yeah.
And that happened in September. So it's like I guess the stages of recovery are always different depending on the patient, but I would assume physical therapy is kind of that first best bet.
Yeah, what I always tell patients is you have to be ready to invest in yourself, right? So this isn't the kind of thing that, I do my part and we're done.
Mm.
If so, everyone would do perfectly. I mean, that, in theory, right? That would be great. But what I'd like to tell patients, especially the morning before surgery, is that I got the easy part. I do a lot of shoulder replacements. I know what I'm doing. I enjoy what I'm doing. And we're going to give them a great looking shoulder. Then they've got the hard part because they've got to work. If you don't move it and you're hurting and you don't feel like, really working it, you're going to get a little stiff. If you don't spend that time with therapy, you're going to have a much slower recovery. So all of those factors are very important in terms of getting patients back to their, same level of function.
And you mentioned that you do a lot of shoulder replacement surgery, shoulder surgeries in general. Is that what most of your day-to-day monthly is spent doing on the orthopedic side, or do you do other sort of orthopedic surgeries as well?
Yeah, I'd still say it's kind of a smaller fraction of the arthroplasty part of my practice, the replacement part of my practice. I would argue that I do a large number of shoulder replacements, but in general, as a general orthopedic surgeon, I still do more knee replacements.
Yeah.
Knee replacements are just the most common joint to be replaced. But between hips and shoulders, I'd say I'm fairly close, if not just a little bit behind, on shoulder replacement. So it's a large number of my patients that I operate on. But it's also just something that I'm pretty passionate about.
Yeah. And we mentioned a little bit about some of the symptoms earlier, but if someone's listening or they're watching and they have some of these symptoms, what is the next best step for them to take towards potentially having surgery, having a replacement, or whatever that stages of
Sure.
their care needs to be?
Yeah, I guess my advice would be kind of depends on, is this acute or is this chronic, right? Did they just have an injury, or, is this something that has been going on for several months? If someone's just had, and I give this advice to my friends all the time, if someone's just had an injury, always certainly think it's reasonable to give your body a couple weeks, right? If you can tolerate it, just to see how it does. Now, if you have no function, you can't lift your arm, I would go be evaluated. But there's plenty of things about the shoulder, because it is a complex joint that you can sprain, strain, and it can improve on its own. Beyond that, if someone has a deep pain, just at mid range of motion, not reaching out to the extremes, but just all the time has limited motion, those are signs that they have, arthritic changes to the shoulder. And I would, reach out to either their primary care or directly to an orthopedic office. I mean, a majority of us, depending on the insurance, you don't have to have a referral to be seen. And, one of the first steps is we're going to x-ray that shoulder I have plenty of patients that say, "Oh, I'm sure my shoulder has horrible arthritis," and I can walk in and say, "Well, good news is your joint looks pretty good. We got an X-ray, and
Yeah.
it doesn't have significant arthritis." But that's one of the early ways we can kind of start guiding them.
Awesome. Well, I appreciate you taking the last little bit talking about shoulder surgery and kind of your experiences here. I think the information that you've provided, I think is good for, myself included, but also the listeners that might be experiencing shoulder pain themselves, kind of knowing what level of symptoms they have and kind of what the next best choice is for them. We'll have all the information in episode notes. If anyone wants to find out more information about anything we've talked about, they can visit that. But I appreciate you being here today.
Yeah, absolutely. Thanks for having me.